Good evening, everyone. I request all the participants to please uh, mute the speakers. 1 second. Okay. Okay. Good evening, everyone, and welcome to today's webinar. On behalf of Mediversal Academy, thank you all for joining us. So today's speaker of the day is Dr. Bharath Sargur. Dr. Bharath Sargur is a dedicated family medicine physician with expertise in preventive cardiology, diabetes care, and internal medicine. He's a graduate of Erwin State Medical University, Armenia. He also completed a DNB in family medicine at District Hospital, Ballari, along with the advanced training in clinical cardiology and evidence-based diabetes management. Dr. Bharath has also served in institutions including NIMANS and Karnataka Brain Health Initiative. Currently, he is working as a consultant in family medicine and preventive cardiology at Prabhu Multispeciality Hospital, Pollachi, with a strong focus on compassionate and patient-centered care. Over to you, doctor.
Yeah, thank you. Thank you so much for that wonderful introduction. Hi, everyone. Before going into the session, I have created some small quiz-like session. It will be a pre-test and post-test. This just like an how we are going to understand this topic and what are the things that we had understand these many days. And Kiran, can you post?
Yeah, I'll be sharing that. Right.
And we can give some 10 minutes for that question and answer session, and we can start it after 10 minutes.
I've sent the quiz in chat.
Once if everyone finishes, kindly let us know in the chat box.
The quiz questions has been sent in the chat. I request all the doctors to fill in the form.
Kiran, can we start the session?
Sir, some 2 to 3 doctors have filled the form. You can, I mean, they've taken the quiz. You can check the form.
Okay. Start ಮಾಡ್ಬೋದಲ್ಲ?
Yes, doctor, please start.
Yeah, thank you, Mediversal, for providing me this wonderful opportunity. And I welcome all the participants for this wonderful session. So going into the session, we'll be seeing about the introduction and classification of stroke, signs of stroke, triage and category of stroke, screening tools, challenges in screening, and stakeholders' responsibilities. An introduction. What is a stroke? A stroke is a sudden onset of non-convulsive focal neurological deficit associated with imaging evidence of infarction or bleed in the territory corresponding to that of the deficit. And we have different terminologies like hyperacute stroke and transient ischemic attack. For example, hyperacute stroke, when we will tag the patient, is like when the patient is presenting within 8 hours of the onset of the typical stroke sign and within 24 hours of the atypical stroke symptoms. regarding this atypical stroke symptoms, typical stroke symptoms, I'll tell you in further slides. And transient ischemic attack is sudden onset of non-convulsive focal neurological deficit corresponding to the focal ischemia of brain, retina, or spinal cord. The typical duration of the deficit is less than 1 hour and mostly around 15 to 30 minutes. Any deficit persists beyond 30 minutes needs considered to be the clinical stroke and evaluated emergently as a hyperactive stroke. See, nothing like a focal neurological deficit has happened, and we all know the golden window period is like 4.5 hours. So whatever the stroke patients, if they are coming between 8 hours of the onset of typical stroke signs, within the 24 hours of the atypical stroke signs, we'll categorize them in the hyperactive stroke. In transient ischemic attack, it's like sudden onset of non-convulsive neurological deficit within a period of mostly it will be around 50 to 30 minutes. One episode that should happen within 24 hours of duration, but it should not persist more than 1 hour. So if it is persisting more than 1 hour, we will tag them in the hyperactive stroke. And wake-up stroke. Stroke occurring during sleep and whose exact onset is not clearly delineated. And last known well, the time where the patient was last seen apparently all right. So what does that mean? Is like whenever the patient is waking up at around 6 o'clock in the morning, and whenever he's about to get down from the bed, he's feeling that neurological deficit is like wake-up stroke. And last known well is like, for example, around 2 o'clock he might be going for the voiding of urine. At the time, he would have been seen normal. So that time we can take it as the last known well. So someone has raised the hand. Dr. Mohammed Aslan. Going into the epidemiology, stroke is considered to be the second leading cause of death worldwide, with 6.2 million dying from stroke in 2015, an increase of 830,000 since the year of 2000. And in 2021, as per WHO ICD-11, stroke is considered to be as the third leading cause of death next to the ischemic heart disease and COVID-19. In India, the stroke death rate was 55 per 1 lakh population, which gone into higher side compared to the 1990 ratio, which was 44 per 1 lakh people. In 2019, Indian national burden of stroke was around 93 per 1 lakh population. And going into the classifications of stroke, we all know 85% will be the ischemic stroke and 15% will be the hemorrhagic stroke. These strokes, ischemic strokes are caused by the blockage of an artery, or in an instance, either artery or a vein. Hemorrhagic strokes, these are the strokes which are caused by the bleeding. Signs of stroke. So typical signs of stroke, it was mentioned in the Cincinnati pre-hospital stroke scale. The Cincinnati pre-hospital stroke scale is like we have the FAST acronym. So it is like facial weakness and facial drooping or arm weakness, slurring of speech, and time of onset. That we will consider as the typical signs of the stroke, which was shown to have the excellent reproducibility with the overall sensitivity of 66% and specificity of 87% for stroke overall. And anterior circulation stroke shows sensitivity of 88% with less sensitivity to posterior circulation strokes. Visual changes were seen in nearly 14% of the patient, whereas imbalance and dizziness were reported nearly in 40% of the patient, which might or might not overlap with the fast stroke symptoms. See, anterior circulation will be having that fast acronym. So it has around 87% of specificity. But regarding the posterior circulation, which had a balance and vision disturbance, that we can't tag it with this mnemonic alone, fast alone. So for that, American Heart Association came with another mnemonic called as the B fast. So it is like anterior circulation is also covered and the posterior circulation is also covered with the extra word BE. That is, B is like stands for the balance, which will denote the cerebellar impact, and posterior occipital area strokes also will be covered with the eyes like blurring of vision, which is also added with the fast acronym. So whenever the patient has these signs like balance is lost, or blurred vision, or facial facial side is a drooping of face, or arm weakness, speech difficulty, and time of onset, which we should consider it as a typical symptoms of the typical signs of the stroke. And triage and categorizing of the stroke. So we'll be categorizing the stroke into the 4 categories. Category 1 is like immediate. It is life-threatening condition that requires immediate attention. Immediate treatments improves the chance of survival or reduces the chance of disability drastically. For example, cardiac arrest, choking, and convulsive status epilepticus. Category 2 is emergent. Conditions that are to be attended within 15 minutes of admission. Example, hyperactive stroke. Category 3 is an urgent condition that can be attended within 1 hour of admission, has less severe symptoms or an injury. Category 4 is like non-urgent. Can be attended after or can be referred to the outpatient clinic. Stroke patient with respect to the triage. How we will be triaging the patient with in the stroke cases. Category 1, and any patient including the stroke patient, any patient including stroke who are unconscious or apneic or pulseless. Category 2 is patient screened positive for typical signs of stroke. So the typical signs of the stroke here, it includes the BFAST. Within 8 hours of onset or atypical signs of stroke lasting for 24 hours of onset. Category 3, patient screened for typical signs of stroke but beyond 8 hours of onset and an atypical sign of stroke beyond 24 hours. Recurrent TAA, that is like more than 2 events, more than 72 hours and less than a week. Category 4 is stroke or TAA more than 1 week old. So basically what is the funda is like category 1, category 2, category 3, category 4 is like severity based we are calculating. We are triaging the patient. Category 1 is like full blown stroke. We'll be saying it as patient will be like apneic and pulseless and it is like we need an emergency, we need an immediate intervention like craniotomy, like that conditions we need to do. So we'll be categorizing in the category 1. Category 2 is like within the extended thrombolizing window. So within 8 hours of onset. So we'll be categorizing in the category 2. Category 3 is like within thrombolized window and recurrent TAA, more than 2 events. If TAA is there, means we'll be categorizing in the category 3. And category 4 is like it is the first episode of TAA. And we are going into the screening tools of the stroke. It is like NIHSS score, National Institute of Health Stroke Scale, modified ranking score, and ABCD 2 score to assess the risk of the stroke after TAA. So these are disability score is like modified ranking score, and quantification of stroke is like National Institute of Health and Stroke Scale, NIHSS will be saying it as. And this is like ABCD 2 score is like to assess the risk of the stroke after TAA. Important conventions are like administer the scale items in the exact order, avoid coaching the patient. See, before whenever you are going to assess this NIHSS score, we don't say how the patient has to respond to your commands. Just let them do their own. And accept patient first effort. Score only when the patient does. Be consistent. Include all deficit in scoring. So this is NIHSS score. So the total score is the total score is around 42. So what we will calculate in this thing is like less than 5, we'll treat it as a minor stroke. More than 5, whatever may be the score, we will treat it as a major stroke only. So less than 5 within 4 hours of period, we won't thrombolize. If it is more than 5 within 4.5 hours of golden period, we'll be thrombolizing the patient. And whether it depends upon the severity, whether we'll be taking to the IVT or EVT. What are the IVT and EVT? I'll say in the subsequent studies. See, this NIHSS is like whenever you are trying to do in the patient, you should always like experience that making this score before itself. Like whenever you are going into the postings and all, at that time only you should do it in the normal patients and like less severe patients, and then you should try it by your own self, because there is so much false positivity will be there. So prevent that, you should train yourself prior. Okay, so it is like level of consciousness, and 1A is level of consciousness. 1B we should ask about the month and age, and 1C is like blinking of eyes and squeezing of hands, and 2 is like horizontal extraocular movements, and 3 is to check the visual field, and 4 is to check the facial palsy, 5 is like left arm motor drift and right arm motor drift. 6 is like left leg motor drift. 6A is left leg motor drift. 6B is right leg motor drift. 7 is like limb ataxia. 8 is like sensation. 9 is like language and aphasia. 10 is like dysarthria. And 11 is like inattention. So these all scores is like it is available in the MD Calc app. So once the session is finished, you just apply the score in your own patient, and then you can train it by yourself. And whatever the score that you are getting, you just apply it here. So whether it is a minor stroke or it is a severe stroke. If it is less than 5, it is a minor stroke. If it is more than 5, it is a moderate to severe stroke. And ABCD score for TIA. A denotes the age, BC, and C is like clinical feature, and D is for duration and diabetes. So each carries one point. If it is age is more than 60 years, it carries 1 point. And BP is more than 140/90, it carries 1 point. Clinical feature, if it is presence of speech disturbance without weakness, and it is 1 point, and 2 points is for unilateral weakness. Duration, if it is less than 60 minutes, it is 1 point. If it is more than 60 minutes, it is 2 points. And if the patient has a comorbid condition like diabetes, it includes the 1 point. So if the patient is coming at 0 through 3 and 4 to 5 and 6 to 7, it is categorized low, moderate, and high. If it is day 2 of recurrent TAA, 0 to 3 is like 1%. If it is presenting at the day 7, it is 1.2, and day 90, it is like 3.1. So basically, what you will do is like if the patient comes with the TAA, you just apply this, and based upon the score, if it is more than 4, or we can keep it as more than 4, we can start with the antiplatelets, so that the patient will be preventing from the further occurrence of the stroke. So modified ranking score is scale is like to classify the disability. 0 it is like no symptoms. 1 is like no significant disability. Only some symptoms, but able to carry all the usual activities. 2 is like slight disability, able to perform daily activities without assistance, but unable to carry out the previous activities. 3 is like moderate disability, requires some help, and unable to walk alone without assistance. 4 is like moderate to severe disability, needs for assistance for her own daily needs, and unable to walk alone without assistance. 5 is like severe disability, unable to attend own body needs without constant assistance, nursing care needed, and attention is also needed, and incontinence will be there. 6 is like this. See, this is like why we are having this modified ranking score is like to classify the disability. So based upon the disability, our treatment plan is also will be changed. What are the challenges that will be facing in the stroke? It is like early detection, pre-hospital delay. It will be happening in most of the rural areas, and we'll be forgetting to we'll be not forgetting. We don't know the symptoms exactly. The patient attenders, bystanders, they don't know the symptoms exactly, and they will mistake it as a hypoglycemia and other conditions. So that pre-hospital delay continues. That is considered to be as one of the major hurdle in improving the acute ischemic stroke treatment in not only in the United States, in everywhere of the world. That is considered to be as one of the first challenges that we have: early detection and time and sensitivity. Some screening methods such as imaging requires access to advanced technology, which may not be available in all healthcare settings. See, whenever the patient comes within 4.5 years of window period, we need to do CT to confirm whether it is an ischemic stroke or a hemorrhagic stroke. That is like plain CT will be doing, and if it is confirmed as the ischemic stroke, we'll be going for the CT angiogram. These are the basic needs which is needed in the setup to handle the acute stroke case. So once if we are confirming with that ischemic stroke within 4.5, we can go for IVT or EVT based upon the severity. So, but in many of the places, this requires more time. For example, the patient will be coming in the EMR, and someone will be attending the case, and we'll send for the CT. There some delay will be there. So that is one of the challenges that we are facing in our healthcare system. And access to the resource. In many regions, especially in rural areas, there might be a limited access to the specialized stroke center, and affecting timely intervention and diagnostics. So these all will take to the patients to the disability, and it will be time will be more, and the disabilities also will be more. Risk factor identification: hypertension, diabetes, smoking are well known. Identifying individuals at high risk of before a stroke occurs to be as a challenging. Whenever the patient is having comorbidities, the risk of getting the like hypertension, diabetes, smoking, the risk of getting the stroke also gets higher. And various tools, and each tool varies among the different healthcare providers. Comprehensive screening requires expensive diagnostic tools like MRI, CT scans, which may not be easily affordable for especially low resource settings. Lack of public awareness. Many people do not recognize the symptoms, and differential diagnosis like stroke mimic symptoms like seizure, migraines, and hypoglycemia. So we'll further that which within the patient is having the stroke or the patient is having hypoglycemia. We can't differentiate them. This happens in so many rural areas. So coming into the CT aspect score, this is one of the important things that we need to know, basic things. This is only for MCA in fact. We'll be having that MCA territory to M1, M2, M3, and M4, M5, and M6. So, and internal capsule, lentiform. So these are the structures that we have to look into that. So the total structures will be around 10. To compute the aspects, 1 point is subtracted from a 10. The total score is 10. If it is less than 7, it is like a more severe stroke. If it is more than 7, then it is okay. Then it is okay means if it is less than 7 means many of the MCA territories involved. So we need aggressive like interventions like IVT, intravascular, endovascular thrombectomy is needed, or else we need to do craniotomy we need craniotomy and other procedures. An aspect of less than 7 points highly correlates with the negative functional outcomes determined by the disability score. An aspect of 0 indicates the diffuse involvement throughout the MCA territory. Subcortical structures are allotted with 3 points. These are the subcortical structures. I think you can see this. These are the subcortical structures which are allotted with 3 points. And MCA cortex is allotted around the 7 points. These MCA cortex is allotted the 7 points. And here comes the stakeholders' responsibility. See, whenever the center is handling the stroke, it should have the designated post like chief medical officer, designated neurological resident, stroke resident, neurology consultant on call, neuroradiology resident on call, cath lab neurology resident, and neuroradiology consultant on stroke call. So many of the centers, they won't be having these many posts. So what they'll be having is like, they'll be having a chief medical officer, and after that, they'll be having the designated neurology consultant and radiologist. So what we should do is like, first role of the chief medical officer or EMR emergency medical officer is to triage the patient. Whether we need to triage the patient based upon the category, whether it is category 1, 2, 3, or 4, and activating the stroke code. A stroke code should be activated by the chief medical officer or emergency medical officer. After that, the stroke code should be given to the neurology consultant or general medicine consultant, and based upon the severity, based upon that, the neurologist will decide whether the patient needs CT or MRI. If the center is having the MRI facility, it will be within the time window period. If this is less than 4.5 hours and we are having so much of time period, we can go for MRI. Or if the time is very less and the center is having only resource like CT alone, they'll be going for the plain CT. After that, they'll give the stroke call to the other radiologist, and they'll ask for the oral reports, and then after that they'll be activating the stroke code. So here it goes. All alerts are sent to the stroke team and raising the patient with the clinical diagnosis of the stroke within 8 hours of the onset. See, 8 hours is like an extended window period. Usually we'll be following it as a 4.5, 6.5. 8 hours is like what we follow in the NIMS for the certain cases. There would be 2 alerts of stroke code. Alert 1 is for triaging, that will be activated by EMR or chief medical officer. Alert 2, it will be activated at the CT scan center and would confirm whether to go for a stroke code or to cancel the stroke code. So alert 2, it is mostly it is done by the neurologist or general medicine physician. So for an example, Dr. ABC, a neurological resident at emergency, directing the stroke code for a 50-year-old male patient with a UHID so-and-so. Stroke onset is like around 6 a.m. and NIHS is so-and-so for CT scan. So this is like stroke code 1, alert 1. So this alert 2 is like Dr. X and Y so and so stroke resident at the CT scanner updating the stroke code for 50-year-old male patient. The stroke concept is same. NA is so and so. CT is normal and aspect is 10. And CT angiogram shows M1 occlusion. So it is like a minor stroke. Consultant on call, informed and awaiting for the decision. So this is how they will activate the alert 1 and alert 2. And based upon this, they'll decide whether to activate the stroke code or to cancel the stroke code. So the second example is like stroke resident at the CT scanner 2, updating stroke code, 50-year-old male patient, stroke onset is 6 a.m. and aspect score is 10, M1 occlusion, decision for thrombectomy is decided. So bridging IVT, intravascular thrombectomy, and cath lab has been informed, and neuroradiology resident has been informed. So again, it is like stroke resident at CT scanner 2, updating stroke code at onset is so CT shows massive MCA impact, aspect 3, code cancel, consultant informed. So based upon your intimation to the consultant, based upon your intimation to the senior officers, the stroke code will be, the call will be taken whether to be activated or not to be activated. This is the basic funda. So keeping this as more simplified, I'll speak to our setup, what we have. So first we will be having an EMR setup where we'll be receiving the patient. Then we will ask the patient what is the last time of seeing normal. For example, if it is an early morning wake-up stroke, we'll be considering it as, they'll be saying it as at 2 o'clock I went for the restroom. That was the time which I was normal. After that, I don't know what it has happened. So we'll be considering it as the last seen normal is like 2 o'clock. After that, we'll be calculating what is the stroke time. For example, now the time is around 6 o'clock means, then it is around 4.5 hours, and we are receiving the patient at 4 hours of interval. So we have 30 minutes to 30 minutes, or we will be taking it as an extended thrombolysis window period for 6.5 hours, or 30 minutes to 3 hours for the time to act by ourselves. So we'll be calling the consultant. Stroke 1, code alert 1 has been done. We'll be calling the consultant and we'll be saying them we have shifted to the CT scan, and the CT scan oral report has been asked, and in the oral report it has been acute ischemic stroke of MCA infarct. And based upon the consultant, what we will do, okay, we can lyse the patient or we can take for the EVT, interventional thrombectomy. Then that thing will be decided, and that will be conveyed to the patient within the duration. Like within the 3 hours, we should finish all those things. So this is the stroke training. Going into the dementia training, introduction, types of dementia, approach to dementia, screening tools in dementia, reversible causes of dementia, and red flag signs in dementia. So introduction. So we all know dementia, will be saying it as an Alzheimer's disease, It is not like that. Dementia has so many types, and it is an umbrella term. Just to keep dementia has been tagged only for a loss of memory and other intellectual disability severe enough to interfere with the day-to-day life. It includes neuropsychological problems, behavioral problems, activities of daily living, and quality of life. Neuropsychological problems include general intelligence, verbal and non-verbal. Memory includes verbal and visual, language, orientation, and visuospatial perception, and frontal lobe executive functions. Behavioral problems include agitation, personality changes, abnormal eating behaviors, wandering, affective and mood disorder, incontinence, anxiety, phobia and fears, delusion and restlessness. Demanding behavior, hallucination, illusions, rage, violence, disinhibition, sleep, wake disturbance, sexual behavior, compulsive and ritualistic behaviors. Activities of daily living includes baseline activities like eating, drinking, toileting, washing, walking and resting. Complex everyday activities like shopping, food preparation, housekeeping, finances and responsibilities. So going into the epidemiology, worldwide around 50 million people have dementia, and there are nearly 10 million new cases every year. 53 lakh people are estimated to have dementia in India in 2020. The number of persons with dementia is expected to increase 76 lakhs by 2030. Although dementia mainly affects the older people, and it is not normal part of aging. Alzheimer's, among the dementia, Alzheimer's disease is most common form of dementia and may contribute to 60-70% of the cases. Dementia is one of the major causes of disability and dependence among older people worldwide. Dementia has physical, psychological, social, and economical impact not only on people with dementia but also on their families and caregivers and society at the large. So these are the types of dementia. Those who are highlighted is like main types like Alzheimer's disease, vascular dementia, mixed dementia, Parkinsonism dementia, frontotemporal dementia. These are the dementias that we'll be seeing in the regular every day-to-day cases. Others like Huntington's disease, Korsakoff syndrome, Creutzfeldt-Jakob disease, and NPS, normal pressure hydrocephalus. So how is our approach to dementia? Approach to dementia is like determine the presence of dementia. Decision is solely and essentially clinical. Determine primary degenerative and other potential treatable causes of the dementia. Comorbid medical illness. Treatment of intervening illness may reverse worsening of the dementia. Evaluation. Evaluation goes based upon the history of presenting illness. Age, younger, it is like secondary causes. Older age is like Alzheimer's disease and other primary dementia. Sex, mostly females are affected more than males. Meticulous histories from independent informant, spouse and patient. Patient with difficulties, what patient feels, what attender notices. See, whenever we are trying to assess the dementia patient clinically, it is like we should ask history from the both from means like from the patient also and from the bystander also. Bystander should be reliable. So it is the person who are living with them daily. So for example, a 65-year-old male patient, he'll be coming and saying like, I lost interest in living, and every day when I go for have food, I don't feel like eating, and wherever I go, I'm missing my keys. So these are the things first you need to ask with the patient, and also this to confirm this thing, we should need to ask to the bystander also whether these things are happening truly or not, whether all those informations are true or not, and only these things are happening, or whether the patient is agitated and are having any other disturbance, are having any other symptoms, aggressive symptoms or not. So based upon that, our treatment plans will change and our investigations also will change. Time course and progression. Early onset is seen in the autosomal dominant subcortical leukoencephalopathy and deficiency states, post-encephalic and SSPE, Wilson's disease, leukodystrophy, and late onset is seen in the Alzheimer's disease. Duration, usually long duration in the Alzheimer's disease and short duration in the chronic subdural hematoma and Creutzfeldt-Jakob disease. Temporal progression, it is usually slow in Alzheimer's disease and relentless progressive, it is in the Creutzfeldt-Jakob disease and Huntington's disease and other infections. Assessment of dementia. Cognitive assessment is done to assess the dementia since patients with the dementia are characterized by the cognitive impairment. So mostly all those patients will be having the cognitive impairment, and brief cognitive assessment will be done based upon the mini mental status examination or Hindi mental status examination. HMSC is like modified tool derived from the MMSC and can be used especially in the socio-cultural context in the Indian scenarios. Everyday ability scale of everyday ability scale of India, a specific tool to screen for impairment function. Basically, what we will in the dementia case, what we will be getting the patient is like forgetfulness will be getting, or else like patient will be agitated, or the delusions will be there, depressions will be there. These kind of patients will come to our clinic, and mostly all those stroke patients, around 40 to 45% of the elderly stroke patients, like above 60, 65 years of age, they'll be having the cognitive decline. So whatever the patient who are having the vascular insult, and those who are the patients who are having the forgetfulness and loss of memory, or behavioral problems, or daily day-to-day activities, they are forgetting something, we need to do cognitive assessment. The basic cognitive assessment is done by mini mental status examination. If we suspect something and we need to go deeply, means we'll be going for the Montreal cognitive assessment, MOCA scoring. And we need advanced means we'll be going for the CogBat, which is like cognitive assessment battery. That is done with the help of system and computer-based it is. And now so many assessments like AI-based diagnostic, it has been it is evolving. but it does not come into the stage, but it is getting evolved. So basic is funda is like mini mental status examination. So in mini mental status examination, we'll be asking around set of questions, and we'll be having the maximum score of 30. It is like the questions includes like what is the year, season, date, day, and month. So we all will calculate this question, and we all will give the marks. So if the patient is we are asking what is the year, he is answering around it is like 1990. In session, it is like summer session. Date is around 30, and day is around Tuesday evening, and month is around it is like saying 5th month. So what are the relevant questions he is answering? We'll be giving the mark for the relevant questions. What is the year we are asking? He's saying some other year. We won't give the mark for that questions alone. So after calculating all those these things, total MMSE scoring, we are getting some score. Like it will be, if it is around 0 to 9, we will be calculating it as a severe impairment, and 9 to 18 it is like moderative cognitive impairment, and 19 to 24 it is like mild cognitive impairment. More than 24 is like questionably significant. See, with all these scores, whenever we are doing in the patient, then only we can understand. So if the patient, for example, we can keep consider the last score. Please copy this picture as like in the it has been given. So some patients, they know to copy this picture very easily, and some patients will be having some resting tremors or some other comorbidities. So they will be doing, they will be having all the scores normal, but only this thing they can't do. So because of this resting tremors, so we no need to worry for that, and the score is also will be around. If it is more than 24 also, we no need to worry for that alone. One part alone. So this is like Hindi mental status examination. These all will be translated in the Hindi. Other tools like Montreal Cognitive Assessment Scoring, and ACE, it is like Adam Group Cognitive Examination, which includes attention, memory, fluency, language, visuospatial functions, and computerized neuropsychological test. This is the CogBack, which is calculated with the help of the system, which is quite expensive. It costs around 5 to 6K per patient. So it is done only for the specific patient to find the exact domain, like whether they have attention deficit or memory deficit, or they are having any visuospatial functional disability. So for the specific patient, we'll be using the CogBack. And trial marking test and trial making test, which is used for the short-term recall, and test of attention, alertness, and visual things. And Tower of London, it is like we will be having 3 beats, and we'll be asking the patient to put in the beats that we have kept it in. We will be saying it as orally. Like for example, we'll be having 3 beats which consist of blue, green, and blue, red, and yellow. And we'll be saying put the blue in red and put the red in yellow places. They have to do it properly. So that indicates the planning ability. And figurative memory test, cognitive flexibility, and NBV, it is like NBAC verbal. Other things like Ray Onset complex figure like attention, working memory, planning, visuospatial, and executive functions. And going to see what are the reversible causes of dementia, it is like vitamin deficiency, metabolic disorders, infections, medications, brain injuries, NPH, normal pressure hydrocephalus, depressive disorder, sometimes alcohol-induced dementia, and toxins, sleep apnea, tumorosis. So these all causes the reversible cause of dementia. In a daily OPD basis, we will be handling the patient with the vitamin B12 deficiency and thyroid hypothyroidism and electrolyte imbalance. Those 3 patients will be getting regularly, and they will be having dementia. Once the root cause is treated, so there will be there won't be any memory loss will be there for the patient. For example, if the patient is having a vegan diet for a long time, and we are checking the vitamin B12, if it is somewhere around 40 to 50 minutes, then they will be having a mild cognitive impairment. So we should not tag them into the reversible cause of dementia. So once if you are treating the vitamin B12 deficiency, their cognitive ability will be increasing. So initially we will be doing some MMSE, and again we will be doing the MMSE after the treatment. We can see the improvement in the scores. And the same applies to the metabolic electrolyte imbalance like sodium, hyponatremia. Those cases also will be having the dementia, but that is reversible. Medication causing dementia, which includes anticholinergic, benzodiazepines, antipsychotics includes haloperidol, olanzapine, risperidone, opioid analgesics like such as fentanyl and morphine. Sedatives includes zolpidem, escitalopram, and antidepressants like tricyclic antidepressant, amitriptyline and imipramine, corticosteroids. Antihypertensives includes clonidine, methyldopa, and anticonvulsants like phenytoin and carbamazepine. And H2 receptor antagonists like cimetidine and some others. Some studies show that cognitive decline of chronic use of the ranitidine also, which will be used in the regular prescription. Digoxin and retroviral drugs like zidovudine also will cause the medication-induced dementia. And what are the red flags in dementia? When to refer? See, certain cases we can't treat in the peripheral setup or in the secondary setup. We need the tertiary care center. So it is like if it is an young onset and rapidly progressive cognitive dysfunction and worsening impairment in activities of daily living, headache and vomiting, fever, involuntary weight loss and loss of appetite, inconvenience of bowel or bladder, self-injury or injury to the caregiver, recent history of head trauma, presence of focal neurological deficits such as hemiparalysis. So these are the conditions that we have to affect the higher system. So now we have seen a total outline about how to screen the stroke and how to screen the dementia. So based upon the clinical setup, I will share my experience. So whenever you are attending a patient with a stroke, we should always ask for the time of onset. So whether it is an early wake-up stroke or a time of onset is during the day period, they can say it's roughly around nearby time. So from that, you should calculate the time of onset. If it is less than 4.5 hours, we should act fast and we should do the CT, which is available. If it is an MRI, we can go for MRI. The time is more because the time taken for the MRI to complete is like around 40 minutes we need it. For the same CT, we need only 15 to 20 minutes to do the CT, and we should look for any hemorrhagic stroke or ischemic stroke. If we are confirming it's an ischemic stroke, we should go for the CT angiogram. CT angiogram is to locate the to check the localization, and based upon the symptoms, we should do the NIHSS score. If it is NIHSS is less than 5, we no need to go for thrombolysis. If it is NIHSS is more than 5, sometimes NIHSS is like we can't calculate its exact conditions. Like for example, polio patients or the patient who have quadriparesis, they are again coming with a stroke. We can't imply the NIHSS. Based upon the severity, sometimes we should go. Like for example, full bone stroke. If it is their complete weakness, if it is there and you are confirming it as a stroke, it is not like stroke mimic symptoms. We can go for a thrombolysis within 4.5 to 6.5 hours. That is an extended thrombolysis period. And if the patient is having full bone stroke, like complete MCA infarctus out or like internal carotid artery complete occlusion is there, we need to go for thrombectomy, either intravascular thrombectomy, endovascular thrombectomy. We need to go for endovascular thrombectomy, and we need to refer for the patient for the EVT centers. So EVT won't happen in every center. EVT will be done by only interventional neurologists, interventional radiologists, or interventional neurologists. So that is how you will manage the stroke. And once the patient has been thrombolized in your center, you need to repeat the NIHSS score, and you need to check for the you need to quantify the stroke, and you should check whether the patient is improving or not. So those all time period is like, for example, a patient come at 6 o'clock at the morning. His known stroke time was around 2 o'clock, and we have thrombolized. He is within the thrombolized period, or we have thrombolized him, and we need to repeat the CT after 8 hours, whether to look any bleed is there or not, or whether it is getting progressed or not. So if it is there is no any progression, and he's like coming out, his symptoms are improving, and then it's fine. If it is having a full bone stroke, again it is not improving, we need to go for either EVT or craniotomy if needed. And regarding dementia, the elderly patient, everyone we can't say that they'll be developing the memory loss, and we can't tag that aging is the main. Aging is one of the main causes for the dementia also. So we need to look for the other reversible causes first, rather than rushing into the treatment. We need to look for the reversible causes like vitamin B12 deficiency and electrolyte imbalance and hypothyroidism. That should be our main thing in the primary care. Once if it is all this are ruled out, then we can sit for the imaging studies like MRI to find any lesions that there are not, or any temporal lobe loss, volume loss is there or not. If the volume loss is there, and typically MRI finding is also towards the dementia, then the treatment will go totally different way, and we need to give the counseling for the caregivers first, and we have to inform them how to handle them, and the certain drugs should be started in that, and mainly the caregiver burden we should address that in that case. And regarding the advances, like we have smartwatch, so we can detect the atrial fibrillation by looking into the abnormal beats. So by that we can try to detect the ischemic stroke. And in dementia also we have some artificial intelligence assisted scoring systems that are coming up in future. So based upon that, if we sit and if we are answering some questions, and that will give the idea about whether the severity of the dementia. And other biomarkers like star protein analysis are helpful in diagnosing the dementia in the earliest stage. So I think I've covered. And can we have that questions again so that we can answer and we can have some discussion about the questions also? Kiran?
Hello. Yeah, tell me.
Can you pose that questions again?
Okay, sure. I'll do that right away.
Since it is a vast topic, I hope everyone you have understand, and I have conveyed the way it has been posted. And you can attend the questions, and we can have a short discussion about the questions also.
Doctor, there is a question from the participant.
Yeah.
Doctor, there is a
the
doubt.
question like this. What are the causes of dementia in young? So, thing is like what CADASIL, we can say it as a cerebral autosomal dominant disorder causing the subcortical leukoencephalopathies in young people, and other reversible causes like vitamin B12 deficiency and hypothyroidism, electrolyte imbalance, infections, and subdural hematomas. Uh, these are some of the causes in young patients. And we can include the neurosyphilis also.
Hello, good evening, sir.
Yeah, good evening.
Sir, I have a question that if there is a one stroke patient who already came and treated as an acute stroke with thrombolized with antithrombotic medication, after neurological improvement, we discharge with the dual antiplatelet and statin. Same patient come with us after developing a re-stroke after 2 to 3 months in spite of developing the antiplatelet regularly.
Okay.
So, what is the strategy of treating that recurrent stroke with antiplatelet? Please guide me, sir.
So actually, I think in this case, you have to look for the serum homocysteine levels also. And lipid management is main thing in this managing this kind of recurrent stroke disorder. And if it is serum homocysteine level, if it is more, and there is more chances of getting the recurrent stroke. And if the lipid levels are also, if it is very high, then the chance of getting the recurrent stroke is also more. So in that case, we need to keep an eye on these two things also. And if you are getting the recurrent stroke, you should treat it as like same as an acute stroke. But since it is like within 2 to 3 months, we should consider for an EVT, endovascular thrombectomy. We need it based upon the imaging and severity.
Oh, thank you so much, sir. Thank you for answering.
Thank you. So can we go for discussion? Session is not yet over. We are waiting for everyone to finish that questions. Can we start the discussion? Yeah, the first question, what is a stroke? Sudden onset of non-convulsive focal neurological deficit associated with imaging evidence of infarction, lead in the territory corresponding to that of the deficit. Second is like progressive onset of weakness. Third is like sudden onset of focal neurological deficit. Fourth is like others. So here the correct answer is like option A, sudden onset of non-convulsive focal neurological deficit. That is the exact definition for the stroke. So typical signs of stroke are as per AHA guidelines. Fast,
Be fast.
It's correct. Be fast. So as per Cincinnati score, which is the typical signs. What are the typical signs? I think
B for balance.
Who has answered that? Can you say your name?
Dr. Khairunisa.
Very good. Very good. Go ahead.
B is for balance. Some problem, loss of balance is there. B.
Okay.
And B. E for I mean there is grouping of
yeah.
I. Fast is for face asymmetry.
Yeah.
A for arm weakness.
Very good. Very good. Go ahead.
Yes, and S for
speech.
T is for time interval to refer the patient.
Yeah, definitely.
Immediately.
Absolutely. Very good.
And S is I forget S.
Speech abnormality.
Sorry?
Speech abnormality.
Yes, sir. Speech abnormality. Yes, sir. Thank you, sir.
Yeah, very good. Thank you so much.
Thank you, sir.
What is the reflex called as? Anyone? Vestibulo-ocular, oculocephalic, hearing bureau reflex. Anyone? In the chat box. It's an oculocephalic reflex. Okay. To check the doll's eye movement and nystagmus if there or not. Another question is like a 60-year-old female presented to the emergency department. Yeah, very good. MPY7, very good, correct. A 60-year-old female presents to the EMD in unconscious state with left upper limb and lower limb weakness. What is the category of the stroke? So we have category 1, category 2, category 3, and category 4. So based upon that, what category this patient falls. So we have to triage now. So our main duty for the emergency medical officer or casualty medical officer or CMO, chief medical officer, is to triage the patient and give the alert 1. So in this patient, what is the triage category? Stroke triage category. Category 2, I got the answer from Gaurav. Others, the patient is in unconscious state. So it is a severe. Yeah, very good. Shashi Sharma. It is in category 1. Category 2, yeah, MPY7 is correct. Category 1 is the correct answer. Next question is like a 55-year-old male presented to the emergency department with a slurred speech, confusion, visual disturbance, but without loss of vision, limb weakness. On examination of vitals, BP was 130/80 mm of Hg, pulse rate was 94. RBS was 50 on examination. Tone was decreased over the limbs. What is the diagnosis? Options are stroke, hypoglycemia, seizure disorder. Yeah, very good, Akash Bharath. It is an hypoglycemia since the GRBS is around 50 mg of HDL. So ideal definition for hypoglycemia is less than 50. Very good, very good. Dementia is impairment of neuropsychological, behavioral, activity of daily living, quality of life, all of the above. Tyagarajan, very good. Akash, all of them above. Akash Bharath has answered that. So it is an impairment of neuropsychological, behavioral activity of daily living and quality of life. It affects everything. Okay. NIHS scale is done to qualify the stroke of severity, quantify the stroke of severity, disability grading. It is quantity or qualify or disability. Yeah, very good. Tyagarajan, very good. Quantification score. It is the quantification score. Yeah, Shashi Sharma, it is very good. Akash, very good, very good. And next question is like 65-year-old male comes with the complaints of memory loss and he is a vegan by diet. On examination, he has hyperpigmentation of knuckles and macroglossy of tongue. MMSE score was 24. No any other domain impairment was there. What is the diagnosis? It is a reversible cause of dementia, neuropathy, progressive encephalopathy.
Reversible cause.
Yeah, very good, very good, very good. Sharma, very good. Reversible cause of dementia. Since the vitamin B12 deficiency, macrocytic anemia will be having, they will be presenting with the hyperpigmentation of knuckles and macroglossy of tongue, and some loss of sensation over the peripheral sensations will be lost. So these all are the catchy things in this question for a vegan by diet as also. So vegan will be having vitamin B12 deficiency. The next question, a 70-year-old male came with a difficulty in recall and often forgets the location of keys and gets anger for no reason. On performing, MMSE score was 18. What is the grading of cognitive impairment, whether it is a mild, moderate or severe? Yeah, moderate, very good, very good, very good. So what is the total score of we'll be calculating in the MMSE? Total score, anyone? Total highest score, what is that? No, 30 is the total score, right? If it is more than 24, we can say it is a normal. 0 to 9, 9 to 18, 18 to 24, more than 24. So next question is like 62-year-old female residing in Vijaypura, Talikoti Taluk in Karnataka came in wheelchair, unable to lift a limb, unable to speak for past 1 week. On detailed history, she had lost her son and husband 2 weeks back in an accident. She don't have any other comorbidities. On examination, her MMSE was a 13 and she was not cooperative. What is your diagnosis and what will be your approach?
Convergent reaction or post-traumatic stress
Huh?
or convergent reaction?
No.
It's brief reaction, grief reaction. I don't know.
I think dementia, post-cognitive impairment of a stroke. No. So we have one history. On detailed history, she had lost her son and husband 2 weeks back, and she don't have any other comorbidities. On examination, her MMSE was found to be 30. What trauma?
Post-traumatic stress disorder.
See, in dementia, we need to think about 3D. Dementia, depression, and delusion. These are the triangles. 3D will be safe. So, if the patient is having dementia, we should think of whether she is having depression or not. In this case, typically 62-year-old female having lost her husband and son back to back in an accident. So, this is the typical case of depression. Okay. Depression it is. And we need to treat it with antidepressant. Yeah, post-traumatic depression. Grief disorder. Someone was saying about the grief disorder.
grief reaction after somebody's loss of somebody.
Yeah, it's very good. So because of that, she went into the depression, and because of that, her cognitive decline was there. And after treating her with the antidepressant, she responded very well. Within 3 weeks of antidepressant only, her MMSE was around 23, 22, like that. Thank you so much, everyone. Is there any other doubts are there? Kiran?
Yeah. Thank you, doctor. Thank you for the wonderful session.
Thank you so much, everyone.
Thank you, everyone, for participating actively in today's webinar. We hope the session was valuable and informative. I'll be sending you the Google form. So if you can fill directly, you'll get the certificate. Thank you. Thank you, sir. Thank you, doctor.
Thank you, everyone.